patients who are coming in who have concerns about STDs. So there's several things that you can do after talking and having a discussion with the patient. If they have concerns about a particular STD based on their symptoms, whether they're having yellow or green discharge or some sort of lesion in their genital area, you can either swab that if necessary, if you're suspecting herpes, or you can do blood tests as well, okay? So if they just want general screening for STDs, you can consider doing HIV. They need to sign a consent form allowing that to be drawn. RPR or syphilis through the blood as well. I typically order hepatitis panel since it's just easier. That screens for hepatitis A, B, and C. Yes, hepatitis A is not technically an STD, but it's just part of the panel. Again, it's easier. And there is a herpes panel through the blood. However, it does not differentiate between herpes simplex 1 and or 2. On the next slide, I'll explain that in more detail. There are some swabs, of course, that can be done. If you want to do a wet prep, it can check for bacterial vaginosis, yeast, or trichomonas. That's a swab that just goes inside of the vaginal canal, just swabs the discharge that's there. Sometimes I do have patients who collect this themselves to just explain that it goes, where a tampon would go inside of the vagina, and that they just need to do a quick rotation of the swab, and they'll just collect it on themselves, and then they just run it at the lab, like we normally would do. Otherwise, you as a provider can collect this swab as well if you need to. There's a swab for chlamydia and gonorrhea that needs to go inside of the cervix. Typically, it's left in the cervix for about 10 seconds so that it can collect enough, stuff that needs to be there. It's typically, or does go in the cervical os, which is the hole that you see in the cervix. And then if you need to swab for herpes, the lesions that you see, certainly you can swab for that, and that will differentiate between herpes simplex 1 and 2. And then if you have a male patient or any patient who's coming in for, even female patient who's coming in for chlamydia and gonorrhea screening, you can do it just through the urine. Do not have them wipe their urethra with the cleansing wipe, as that will maybe falsely make these tests negative for chlamydia or gonorrhea. So you definitely don't want them to wipe and clean themselves prior to that urine sample being collected. Gone are the days where we take a swab and stick it up the male urethra to collect discharge for chlamydia and gonorrhea. I do not do that. It's just not something that you do anymore. It's a lot easier just to collect the urine sample. This is the herpes test that I was referring to. So at the top, again, it's not going to differentiate between herpes simplex 1 and 2. It's just a combined test. IgG means that it was gone or in the past. And then if you look below, the IgM is to the minute, which means it would be a current infection. Again, it's not going to differentiate between herpes simplex 1 or 2, which is cold sore herpes versus genital herpes. As you can see for this particular patient, their level for the IgG, or the gone one from the past, is 1.27. Anything greater than 1.10 is considered detected. Most everybody is going to have it detected for a past infection of herpes, most likely related to cold sores. Whether or not you've had an outbreak of a cold sore or not, most people have this just because of how common that is. And then you look at the bottom one, and she's at 0.53 or less. It's considered not detected, so she didn't have a current infection of the herpes virus, so no current outbreak. Again, this is not going to be able to differentiate, so explaining this to patients prior to them seeing their results is important, as they start to have a panic thinking that they have like genital herpes, and that's not always the case. I always explain that if they do ever develop any sort of sore in their genital area, that it be swabbed to actually let us know whether or not it is herpes simplex 1 or 2. You can technically get cold sore herpes in your genital area So it's important that whatever lesion does develop down there, that you get it swabbed. There's a lot of misconception that only genital herpes is only genital herpes and not from anything else. It's just from sexual intercourse, which is not true. You can actually have oral, intercourse and get, herpes that way in the genital area. And so it's important, again, to educate them about that so that they're not confused when these results do, come back. Just saying, most patients who do have some form of genital herpes have these sores that do not go away. Usually they have enlarged lymph nodes in their groin area, pain, and they a lot of times have burning. Herpes is a form of, it's a herpes virus. Essentially, it's kind of like having shingles or chickenpox, where it causes the burning, the ulcerations, the sores, that sort of thing. And it's not something that just resolves and goes away. A lot of women will say, oh, I think I have shaving irritation, but these bumps don't go away. And they've been there for, 1 or 2 weeks. And on examination, you can tell that it's not the case, that it's genital herpes, but you only can know for sure if you do the swab of the actual lesion itself. Treatment for these sort of conditions. Bacterial vaginosis is not technically an STD, but it's something we do see frequently on the wet prep. It's just an overgrowth of bacteria in the vagina. Flagyl, 500 milligrams twice daily for 7 days, or Metrogel, 1 applicator full intravaginally once or twice daily for 5 days is the treatment for this. I typically prescribe Flagyl just because pills are way easier than trying to deal with intravaginal application of medication, unless they are pregnant, and then certainly they cannot take Flagyl, so you'd have to do the, the intravaginal course of treatment. For chlamydia, there's 2 choices for medication, doxycycline or azithromycin. For gonorrhea, the only medication really is Rocephin, intramuscularly, 500 milligrams is a single dose. But 1 gram is recommended for patients that are over 150 kilograms. And if you suspect a patient may have both chlamydia and gonorrhea at your office visit, go ahead and give them the Rocephin and also treat them for chlamydia as well. The chances of them coming back for intramuscular injection of Rocephin is not as likely in every case. And so if they're already there, it doesn't hurt them to give them just 1 single dose of that medication for the treatment of gonorrhea until their results come back completely. For yeast, which again is not an STD, but if it comes back on the wet prep, diflucan or fluconazole, 150 milligrams 1 time, or you can give it 150 milligrams every 72 hours with a total of 3 pills that are given. Diflucan or fluconazole remains in the system for 72 hours, so it does not have to be given daily. I always explain to patients that if you take the first dose, after 3 days you're still having symptoms, take the second dose. If you're still having symptoms, then take that 3rd dose, after 3 more days. If you don't need all 3, that's fine, but, it is what it is. Otherwise, you can also treat with clotrimazole. It's a topical application that's a vaginal cream that you can put in at bedtime for about 7 days. It's used for women who are pregnant because they cannot take diflucan or fluconazole, as it can cause miscarriage. Genital herpes, you can give Valtrex to these patients if they're immunocompetent. The initial treatment is 1 gram twice daily for 7 to 10 days. And then you can also treat their recurrent episodes if necessary, and even give suppressive therapy if necessary, based on the frequency of their recurrent events that they have. So you do need to, of course, keep that in mind. And then for chlamydia and gonorrhea infections, make sure that all of their partners are treated. There's a lot of times where these patients come back and they still have chlamydia despite treatment, that because their partner was not treated. And I always encourage the patients, once you get treatment, you have to refrain from sexual intercourse or any sort of sexual activity for at least a week, so that the medication can take care of the problem for you before you, resume all that stuff, because unfortunately you can be still spreading it or reinfect yourself if your partner hasn't been treated as well. So it's extremely important that they're educated on that too, that they can't, you know, just take the, you know, like azithromycin at 1 gram and then resume their sexual activities, you know, later that day. It doesn't work that quickly in the system. So a lot of times it's just a lot of education for these particular patients in terms of how to manage and treat their infections.